Hi, good morning, everybody. Welcome to the 19th edition of the Health System Fix podcast. My name is Dr. Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist and a health systems design expert. My guest today, I'm very excited, is Dr. Sanjeev Arora. Dr. Arora, by training, he specializes in gastroenterology and hepatology, but he's the founder of Project ECHO and ECHO Institute. Dr. Arora is a distinguished and Regents Professor of Medicine with tenure at the Department of Internal Medicine, University of New Mexico Health Sciences Center. The ECHO Institute he's a pioneer in democratizing specialized medical knowledge for the good of humanity. His idea of Project ECHO was grounded in personal experience, serving patients with liver disease in New Mexico. And over time, this model of training has grown to impact more than 70 different diseases being implemented across the world, including in partnerships with the World Health Organization and the CDC. It's also now ventured in the space of education and also climate change. Project ECHO won the Ashoka Foundation's Changemakers Award in 2007. And Dr. Arora himself has been the recipient of the Lifetime Award by Governor of New Mexico in public service. And in 2021, he was a laureate of the Brock Prize in Education Innovation. I also want to add, I've actually been on both ends of the ECHO project. I've been a learner in one of the projects and also been a subject matter expert in one of them. Thank you, Dr. Arora. Thank you for joining us today.
Thank you very much. Thank you for this opportunity. I want to make one brief remark about this is that I have retired from the University of New Mexico in July and now actually live in Boston. Of course, still very, very deeply interested in ECHO and it's been a great blessing and honor to be able to develop it.
I would love to start with asking you some questions about your early life. I'm interested in system change work that you have done for decades now. I'm interested in how do people arrive at some opportunities or ways of thinking and how they're doing the systems change work. Can you tell us a little bit about what was life like growing up?
So I grew up I was born in northern India, in a state called Punjab. And there's a town there called Nangal, where a major dam was being built. And my father was a physician in charge of the dam. And my mother is an OB doctor there. And so both my parents are physicians. And I was born there and I grew up in northern India in the Delhi region. My father worked for the National Institute of Communicable Diseases, and even as a child, I was allowed at that time to go on tours with him in his Jeep, and I got a chance to see two things. I got a chance to really see rural India a little bit as I was growing up, and it was obviously, I was born in very fortunate circumstances, but it did definitely make a huge impact in my mind to see the tremendous disparity that existed, the amount of suffering that was occurring from disease. My mother ran a small hospital in India. They call it nursing homes. She would always provide care to the poorest of people. So I cannot recall her ever turning anyone away. We used to live on top of the little hospital. So I was brought up in medicine, and then in 1974, I attended Armed Forces Medical College in Pune, which is in the middle of India. And from there, soon after graduation, I decided I wanted to come to the United States. Here, I was trained in New York and then Boston, and subsequently moved to New Mexico as the chief of the section of gastroenterology at the university hospital. Certainly, the first many years of my life were largely spent on developing myself. I had children, and actually ECHO came significantly later in my life, but in the beginning was just, promoting my learning, growing professionally, and looking after kids. And of course, I had the support from my lovely wife, who's an internal medicine physician.
Obviously, the journey you're talking about and kids and professional growth all tends to happen around the same time. When you first moved, what differences did you see back then when you first transitioned to the US?
So when I was doing my internship in India before I moved, I got to see the Indian healthcare system close up for almost a year and a half. And there was a tremendously resource constrained environment. This was 1978 and 79. I remember in a big ward where I was in charge, we would have 16 x-rays in a month to do. And, there were 40 patients in that ward. A lot of the blood tests, etc., that we had read in the books, what we would say serum electrolytes and liver function, were not freely available. So everything had to be done clinically. So it had its blessing that we had to hone our clinical skills, but it was very difficult to provide best practice care without appropriate testing being available. So I think there was a lot of poverty. Now, of course, India is in a very different phase of its development. This is now 47 years later we are talking about. And I left India in 1980, and that's 45 years ago. I think at that time, but we were still reading the same textbooks. Remember, we were reading Davidson's textbook of medicine and Harrison's for medicine.
Yeah.
So the textbooks were disconnected with what was actually happening in our clinics. So, but I came here, I thought, let me go and actually learn what medicine is really. And my father had come to the United States several times, and he worked then for the World Health Organization. And I was definitely enamored by the United States ethos of literally serving the poor, giving back. There used to be the Peace Corps at that time. It was a very important thing. That was the years when John F. Kennedy was saying, ask not what your country can do for you, ask what you can do for your country. And so it was a different time, and I was intrigued. I wanted to come here. I wanted to train. So I came here in 1980.
What were some problems that you ran into in patient care that started making you think, okay, this is not working for the patients I'm trying to serve? And then that eventually maybe led to the ECHO project.
When I first came to the United States, healthcare here was different. It was a fully private system, but there was a very strong ethos that every single person, regardless of their ability to pay, would get excellent care in the United States. This was 1980. The HIV epidemic was in full swing. And a lot of the people didn't have insurance, but they were getting amazing care. Over the years, what happened, I saw that there was a change in that ethos. More and more, two classes of care occurred. There were the have-nots who were not able to access care. And then there were the haves who were getting the best care in the world. And this situation continued to worsen very gradually, perceptibly, year after year, over a period of 40 years. At one point, what happens is that the fee-for-service system took such massive hold on the American healthcare system and procedures. I happened to be on the sweet end of this deal, being a gastroenterologist. We're getting differentially reimbursed. So the system started shifting towards procedures and tests, etc. And primary care kept getting de-emphasized because the payment systems did not reward it as much. In 1993, I had been living in Massachusetts, which is one of the most affluent states, and there's a lot of healthcare providers here. But when I moved to New Mexico, I encountered a whole different situation. I was the section chief at the university hospital, and 50% of all the people who were coming to our section of gastroenterology had no insurance. We were the city hospital. We were the state hospital for poor people. The hospital did not have a lot of resources. And so there was a tremendous strain for poor people to get specialty services. It was very hard. And this was the circumstance in which I was practicing for about 8 years, trying to provide as good care as I possibly can. One of the reasons I went to New Mexico was that I found this challenge to be intriguing. I said, look, I'm going to go and try and provide care to these people, because as opposed to Massachusetts, where they had access to care, over there was no access, and I could make a real difference there. So I go there and I start treating hepatitis C and I'm also doing a lot of procedures and really working extraordinarily hard. And this is when, in 2001, I see a patient who passes away, and I decide that I'm going to devote the rest of my professional career trying to solve this problem, basically, of access to specialty care for low-income people.
When you were first envisioning how you would do this, what was the initial idea you had about how am I going to change this?
Yeah, so what happened was that there was this disease of hepatitis C, which was a poor man's disease, and a lot of gastroenterologists were not at that time deeply interested in treating it. Treatment was complicated with weekly injections of interferon and ribavirin, and there was no treatment available easily to patients. So I said, let me develop this as my specialized clinic in it so that I can provide that service. And in 2001, I saw this patient who came to see me, and she was 43 years old, and there was a 14-year-old boy and a 9-year-old girl sitting in the room. And I asked her, how can I help you? And she said, I have a hepatitis C and I want treatment. So I said, I'll treat it. How long have you had it? And she said, I've had it for 8 years. So I said, why did you not come earlier for treatment? And she said that I called your nurse and there was an 8-month wait to see you. And which was true. And that I would have to make 12 trips to see you, but I live 200 miles away. I'm a single mother. I can't take that much time off work. So I decided not to get treatment. They said there was no one, actually in New Mexico, there was no primary care clinician who was treating hepatitis C. Zero. And there was no one in her area, and she couldn't come. So I said, okay, now that you're here, we'll treat you. Why did you come today? And she said, I'm having pain here. And I did an ultrasound, and she had a cancer of the liver, and she passed away 6 months later. So I was asking myself, why did she die of a disease that I knew how to treat? And it could have been cured. And the answer was she died because the right knowledge didn't exist at the right place at the right time, and she didn't have the ability to get to the right knowledge. So fundamentally, that was the problem that was that day impacting low-income people in New Mexico. It is the same problem that is impacting 6 billion people in the world today who do not have the resources, that they cannot get the right care because the right knowledge didn't exist at the right place at the right time. So in 1993, I had developed, I grew up in India, as you know, and so I had developed a meditation practice, basically. So I'd been meditating for many years in this time. And in December of 2002, I went into a long meditation, basically. And I was asking this question, how can I be of service? And I got this idea of the echo model, basically. And where the idea was that, look, you should use your time and use this model to democratize your expertise so that everyone can get care. And then it was obvious if I could do that, this could be applicable for any disease. It could be applicable all over the world. And the idea was a 4-point model. It's like 4 legs of a chair. To use technology to leverage expertise was the first part of it. Second part was to share best practices. Third was case-based learning and what we call all teach, all learn. And fourth was outcome tracking. So I went around the state of New Mexico and I talked to primary care clinicians everywhere. And I would give them a speech, give them CME credits, teach them. And I would say, look, people are dying from hepatitis C in your community. There were 28,000 people who had already been diagnosed in 2003. Only 1,500 had been treated. So I said, look, people are dying. They'll keep dying unless one of you steps up to help them, because specialists are not moving here. These are very remote areas. So I'd find one primary care clinician, and then this way I found about 21. I taught them. But they said, look, we can't just treat like this. We are primary care clinicians, and this is like light chemotherapy. So that's when I had come to the second principle of sharing best practices. That's when I asked myself, how did you become an expert? So when I did my fellowship in Boston, I would see a patient present to my professor, see another one present to my professor. And after 2 years, they said, you're a gastroenterologist. I said, aha, I'm going to use this model of case-based iterative guided practice to create new hepatitis C specialists in New Mexico, not gastroenterologists, just experts in this one disease. And we would track outcomes. In 2003, the first echo clinic started on a Wednesday afternoon, and then it still goes on every week. I was doing it in collaboration with a infectious disease doctor called Dr. Carla Thornton, a psychiatrist. And we would sit and these 21 would join like Zoom conferences now or Hollywood Squares and one by one present patients of hepatitis C to the three of us at the university and to each other. And we discuss 7, 8 patients and we give them a 15-minute lecture. As I did this week after week, 1 year later, they were experts. And in 18 months, the wait in my clinic fell to 2 weeks from 8 months. And over the next many years, more than 10,000 patients got treated. And we could see that the results were excellent. People were getting cured left and right. So that was very encouraging when that happened.
That's amazing. Even the problems I faced in implementing mental health programs here in California and the barriers you talk about is often not the science, the medication, or the treatment modality. The barrier is the transportation for the patient. The barrier is the person, the PCP or the frontline person interacting with the patient, do they have all the tools to actually do this work?
Exactly. And I think that's where the solution, since you're an expert in health system design, the solution to the health systems in many, many parts of the world, including the United States, is by bringing the right knowledge, the right expertise, and the implementation of that expertise to the last mile. And nowadays, with technology, that can happen. And so this is where Echo started and then started growing in an organic way.
Yeah, and even how I think about building a new program is thinking of human-centered design, and we are obviously focused on our patient, which is our goal but it's a two-layer human-centered design. What does the patient need, and what do the people who are going to serve this patient need? And which is exactly what you were doing. You were enabling the frontline team to actually do the work.
Yeah, and one of the greatest surprise for us, Gaurav, was that it was not just making them experts and patients were getting access close to their home and getting cured. It was producing joy of work for them. That was such a pleasant surprise. It was reducing their isolation. They were feeling supported. They were feeling a part of a team. When you have a complex problem like a hepatitis C and you're alone in your community, that's not easy to tackle. That is a huge problem. Becoming a part of a team that says, look, you go do it, we'll support you, is very empowering. And over time, you gain the expertise, but you also make many friends. And Echo turned out to be a great friendship making machine. I'm sure if you participated in Echo over a few times, lots of friends were made. It so happened many years ago, we did a little survey in New Mexico and we found that child psychiatry was the single most short specialty. That's where they needed the most help because there's so much need and so little expertise in rural areas. So we hope you will start one and help your patients all over the state that way.
I was talking to one of our therapy leaders recently, and one of the things I said was, when you're talking about integrated primary care behavioral health, the first person that you need to think about supporting is not the patient, but the PCP and the team. And if you
Yes.
do that, as you said, feeling supported, feeling as if you're not alone in this work, and also at times feeling ineffective because you don't have all the tools can be huge burnout factors for people, and just providing that support goes a long way.
Yeah. So essentially, once hepatitis C echo started, the key change factor occurred in 2007 when that global competition occurred, disruptive innovations in healthcare that could change healthcare globally. And we got a $5 million award from the Robert Wood Johnson Foundation to show that it can work for other diseases and we can disseminate it in the US. And we started doing that. And to our surprise, the adoption of ECHO was fast. So for example, in California, Stanford, UCSF, UC Davis, they all do ECHO. Similarly, first University of Washington, then University of Chicago, then Harvard, MD Anderson, Johns Hopkins, all these major institutions came on board doing ECHO. We developed a software platform called iEcho, and we decided we would democratize not just expert knowledge, but our knowledge of how to do echo. So we would give away our software for free. And that was a game changer because a university could come to us, and not for profit come to us, and we would give them the technical assistance and the software and hold their hand as they implemented echo. And so currently there are many, many thousands of networks operating out of 1,400 hubs in the world. And these hubs are often government entities. In India, for example, PGI Chandigarh, or it could be Nimhans in Bangalore, or in University of Cape Town in Africa, in South Africa. So slowly, a lot of the major universities in the United States now do it, and it started spreading. And now we have estimated about 225 million patients are getting better care because of it. But at the end of it, it just boils down to a health system design issue. If you redesign our system in the United States to democratize specialized knowledge, we can provide excellent care to everyone. We have enough patients. We have enough doctors in the rural areas. We have enough specialists to democratize their expertise, but we have to want to do it.
It's so true. We talk about shortage of mental health professionals. It's definitely real, but I do think there is also a significant artificial shortage of professionals because let's say I'm in a private practice or I'm in a small clinic. And if I'm seeing a patient with mild depression or anxiety, I could do that by myself. But if I'm seeing a patient who has more complex illness, bipolar disorder, schizophrenia, or complicating medical factors, I need a case manager. I need peer support. I need a nurse. I need many other team members who are able to support that work to be able to care for this complex patient. And that support network is not existing for a lot of people in the community, because of which the number and the kinds of patients, so very similar to the situation of the PCPs early in those days, where they do not have the knowledge or the team to be able to do that work, which is new and different. That kind of almost restricts the availability of professionals in the big pool of everybody available to do the work. Anytime doing systems work, I've also seen any new idea which seems great also has a lot of resistance to new ideas. So early in those days when you were trying to do this at your university or at the local healthcare organizations, community-based organizations, did you meet resistance in, why are you telling us how to do things differently? Things like that.
I think in my case, there was no resistance because of two reasons. One is, of course, the leadership of the University of New Mexico wanted to help rural patients. But the second was we were able to always get grant support or philanthropic support. Now, as the project became successful, the legislature started supporting us with the university, with funding for ECHO. And so that was able to cover the time of the specialists, etc., and the staff and the technology. But the challenge still remains in the United States that there isn't a very specific line of funding to support the democratization of expert knowledge. That is required.
Yeah.
One can never imagine a situation that you'll have a child psychiatrist in every small town in the United States. It's not going to happen. So it needs a re-engineering, and the fee-for-service system is really not designed to provide equitable care for all. And so this is fundamental conflict in that when so many parts of our system are working towards improving revenue as their major goal, whereas the goal of patients is better access, higher quality, lower cost, and being treated in a kind, respectful way, some of these patient needs get a little bit shorted, in the sense they're not able to get the full attention because so much of the system is being driven towards maximizing revenue. So this has to be reconciled in some way that we create a system that is aligned with the needs of patients, the needs of clinicians to be supported, to learn. We are in a very intriguing time in this world where knowledge is exploding at an exponential pace. And this is occurring because of big data or because of biotechnology and human genome sequencing and Moore's law for computer chips, computational ability, clouds. But the net result is exponential increase in knowledge. If you think that a nurse or a primary care clinician or a community health worker in a rural community is going to have the time to keep up with all of this. On the other hand, if we take a few of the most common healthcare problems, okay, like diabetes, hypertension, cholesterol, or the metabolic syndrome, you take diseases, prevention of heart attacks, etc. You take chronic pain, you take mental health disorders and addiction, you take a few others, a few important ones, and create expertise in the rural communities. You can transform the healthcare system and dramatically reduce cost and improve quality of care.
Such a great point. By the way, I have used democratization of knowledge and power in similar sense, like example of Uber in transportation, growing from days of calling the cab and hoping they show up to Uber, the kind of power a consumer has today, to kind of hopefully getting to a place of similar power in the hands of our patients. And it's fascinating how all of this knowledge, the way it's implemented, is going to make the difference or not. As you said, does a nurse or a physician in that rural clinic have the time to process all of this knowledge? The problem in our health system often is also a lack of actionable knowledge. In that first example of the echo, you gave people an explanation of the disease and the treatment modalities, and you had a place for them. That knowledge that you were providing was not just a lecture, it became immediately actionable, and that
Yeah,
made the knowledge different.
that is key. See, the traditional model of CME is like teaching your daughter to drive a car by giving her lectures, you see.
Yes.
What they need is you need to sit next to her and do iterative guided practice. And so there's a generic principle here, Gaurav. One is that's whenever there is a problem, what we call dynamic complex problem, dynamically and complex, that is changing and it's complex, you need guided practice. You can't just, take lectures and implement. That's how airline pilots said, your daughter to drive a car, surgeons. I learned that way as a gastroenterologist. You learned that way as a clinician, because otherwise they just give you the Harrison's textbook of medicine and say, go practice. And so even now you'll hear a lot of words like, AI and all that. The issue is who's going to teach this doctor in rural Ethiopia to use AI correctly for his patient? It's a complex issue. I'm trying to learn more about AI in my retirement, and I'm saying, wow, this is complex. But it's also powerful.
And we can say rural Ethiopia, but the fact is, I was an SME in a project Echo. I was teaching PCPs and nurses about basic mental health exam and treatment. And I was giving the same lectures here in San Diego to our PCPs. The knowledge gap in Congo and the US, in urban US, where it's the same.
But there is a lot of joy when you spend your time serving rather than just your business. And I think there's room in the United States healthcare system for the fee-for-service system to exist. But, there is a very strong principle of tithing in the United States. So one can easily imagine that a doctor such as Gaurav Mishra spends 10% of his time doing what is called seva in India. It's called tithing in the Christian faith. It's called zakat in Islam. But, there is room for that. And even a small amount of time spent in giving back to the community can be transformative for our health systems.
So let me ask you for advice. Generally I don't ask for advice in a podcast, but I've been thinking about the system of care we have in the US about dementia. And I'm a child psychiatrist, but I'm seeing all ages of patients, youngest being 2 or 3, oldest 89, 92, something like that. And this is a very distinct experience that I had with one of my patients who walked into my clinic the first time she did. I believe she was 89, just had a stroke, and she had significant cognitive decline, psychosis. And then obviously with some medication, but a lot of physical therapy, a lot of socialization. 2 years later, when I saw her for the last time before I left that clinic, she was doing better than when she first walked into my clinic, which is not a common thing if you're working with patients with dementia. And the family was thanking me, but I know for sure, and I told them, Medication was maybe 2 or 3%, 5% maximum of what that patient benefited from. I had a role in that, but the rest of it about socialization, family engagement, physical activity, really what made the difference. But most of our health settings, we do a significant disservice on how we are engaging with family and support. So I've just left my job as the chief behavioral health officer in a large community health center after 6.5 years. I've been contemplating on this problem and thinking about creating a program or helping somebody create a program around dementia care. The hesitation I have is that I didn't want to necessarily set up a clinic of my own just by myself. So the question I think I'm asking is, there is no way to do it from the outside. You have to jump in. Only that is the only way to really solve such problems.
It sort of depends on what your goal is, okay? If the goal is health system change and service to the community, it can be done. But if your goal is also simultaneously to create a very successful business, which, you're a young man and that's absolutely necessary, then that would have to be a business. One can easily design an echo for dementia, where there's training of primary care clinicians, there's training of family members, there's training of lay people who can deliver physical therapy. There is training of lay people who can assess for medicine, interaction, side effects. There's a lot can be done, okay? Really a safety net around every dementia patient, making sure it's not drug toxicity that is causing it, making sure the diagnosis is correct, making sure there's not a mental health disorder, it's actually Alzheimer's disease. Plus, ensuring that the home care team is fully trained. And so there is definitely a massive opportunity there. And dementia, the organization in the United States that deals with it, the not-for-profit organization, they use the echo extensively for that purpose. Now, that's one aspect of it, but this is the seva aspect or the service aspect. There is also a tremendous opportunity to create either a residential facility or a dementia-focused practice in which you are able to provide a comprehensive set of services. And it involves training of the family, training of everybody who is part of the ecosystem. Because this service will be expensive for them, so it'll be necessarily confined to people who have the resources to cover that. But then you can imagine, after you set up this dementia clinic, to actually use something like Echo to continue to train the care teams that exist of the thousands of patients that you may have. So one can set up a system, because one of the challenges that exists is for dementia patients, care at home is very hard because the family doesn't know what to do. And there are not enough residential facilities. The third opportunity is obviously from a business perspective is to create a residential facility which provides best practice care to dementia. And there are many best practice examples of that. And so I think the field, what you've identified, Gaurav, is a massively underserved field with a very growing population. So there are many ways to address it.
Right.
From different angles. But the most important thing is to clarify the goal. The goal is essential. The reason why Echo was successful was because the goal was very clear. There was no business goal here, no business interest here. And the only reason that was possible was my wife and I, my kids had both gone to college, and we didn't need to create a business. We were in a stage of our life to give back now.
So yeah, I appreciate you walking through that real situation. Couple other questions. As you trained in medicine, went through specialty training, and there is a path to grow in that role. And then you start Echo, which was a totally novel, different model than you were traditionally used to in the medical world. Did you find places that you needed to increase your skills? Did you do things along the way that kept your skills up to manage this big thing now that's impacting so many people?
I have a management degree too, which I got from the American College of Physician Executives and Tulane University. To be quite honest, A lot of this is somewhat common sense, I have to say. And I had a reasonable business sense anyway. So I did have that degree. I sort of understood some of the basic principles, but really what drove it was a shift that I would spend the rest of my life giving back to the community. That was the fundamental driver, because it wasn't so much management skill. See, when you're starting a business, Gaurav, what happens is the people attracted to you are people who want to do business. When I started Echo, the people who came towards me were extraordinarily mission oriented people. They wanted to change the world. And so it starts there. It starts with your, what do I want? Okay. The most difficult question in the world for a talented person like you, Gaurav,
Right.
is what do I want? Because the choices are enormous, but having clarity on that. And because with God's help, I knew exactly what I wanted and I put it out there to the whole world. I said, we are going to help 1 billion people. So the moment I put that goal out there for the whole world, and we put it in public, every one of our partners who joined us, in 100 of them, we told them, what's the goal? 1 billion people. So that clarity of goal and then setting a clear target. What am I trying to achieve here? Okay. And then everything else falls into place.
Yeah, you've given me so much to think about. But let me just ask you about the vision piece again. You talked about meditation and that helped you hone in on how you want to do something, like how you want to solve the problem you're facing. The clarity of how big you want it to be, how much impact was that right at the beginning? You just felt it strongly, or did that evolve?
Yeah, so this was the sequence. Okay. The first thing was that through my meditation practice, I got to a place that I was basically saying to myself that you have been given so much by the universe, time to give back. So then the next question that came was, what does that mean, giving back? Being a doctor, I've been serving patients all my life. I am giving back a little, but the primary purpose of that work was still related to, my salary, my professionalism, all that. So that shift that I'm going to spend the rest of my life giving back was the fundamental shift. The next question that in meditation, I was not asking the question, should I give back? I was asking the question, how should I give back? That's how the echo model came in, is that, look, this is your expertise. You are a system thinker. You have this unique expertise. Create a system that can fundamentally transform things, okay, if adopted. Now, as you pointed out, adoption of such a system is not easy because systems have entropy. They're going to want to gravitate towards where they sit today. Plus, there are multiple stakeholders who have individual interests. Those interests don't go away because one stranger comes along and says, I have a new, better system, Those interests have to be reconciled. So the change will inherently be slow, but the path is set. And so, but this could only occur because I was in a situation that I didn't need to focus on accumulating more. I was in that different phase of my life. And I'd been meditating for 8-9 years and reflecting on what brings true happiness to a person. After all, why do people want professional advancement or money? Or they want happiness and joy, and they are trying to find ways to get it. So for me, the key insight that came, which is still true after 20 years, is the only way for a human being to be really happy is to live a life of service. There's no other way, basically. You can't just pray your way, sit and pray for 8 hours and hope that, you're going to be a happy man. It doesn't work like that. You've got to serve humanity. There's no other way. So once that insight comes that there's no other way, then you say, okay, let me get my act together and figure out what I should do here. And it doesn't mean you don't look after yourself. All this time, I was still a professor. I was getting paid very well. My wife was getting me, it was not that I was starving here, but the principal goal was very clear. And I found that a lot of people, very talented people like yourself, often don't get the level of success they should because there is lack of clarity of goal.
Last question. Do you mind sharing your meditation practice? What is that like?
Sure. There's an organization in California. Which part of California do you live?
I'm in San Diego.
Yeah, so they're called Self-Realization Fellowship. In fact, they have a garden there called in Encinitas. You must visit that. It's beautiful. You been there?
I've been there, yeah.
Yeah. So 1993, I read this book called Autobiography of a Yogi, in which he describes a meditation practice called Kriya Yoga. And I read that book, and one of the things that was really touched me greatly, I don't know if you read that book, but that's a must read. I'm sure you
I'm
like to read.
halfway through it.
Okay. And there's a person in there called Sri Yukteswar, and he says, grateful service is the rent you have to pay for living on this earth. And that always struck me. He said, this makes sense. You can't just, consume, consume, consume and not. So I belong to that organization. I come to that part of the country often, but that's been a life changing, but I'm sure there are many, many ways to do it and many paths to get there because the principles are universal essentially. And what I liked about this particular road was it's about all religions as opposed to saying this is better than that or so on. Yeah.
Great. Dr. Arora, thank you so much. It is such a pleasure to talk to you. Obviously, the impact you have is incredible, and I'm hoping to see in what ways I can continue to make some impact, right, in the community I'm in. And so your work is obviously very inspiring. So thank you for taking the time today.
Yeah. Thank you.